Okay, good afternoon, everyone. Please take a seat. So first of all, normally the thanks are at the end of the session, but I would like to start by thanking you for being there. It's 5:20, a very busy day, but I think it kind of closes the loop because we started this morning in the main arena with the session on tricuspid, transcatheter tricuspid innovations, and we are closing the day with another session on tricuspid transcatheter valve replacement technology. So innovation never stops. We're going to discuss about the Cardiovalve transcatheter tricuspid valve replacement solution. So I have the great privilege today to work and to co-moderate the session with Rodrigo Esteves Loureiro. You've seen him in action all the day, I would say, in the main arena. So thank you for moderating the session with me. And Sergio Berti and Federico Di Marco are going to be part of the session to try to address your questions, guys. So the room is perfectly suited for making sure that you get all the necessary information that you are in demand of. So feel free to use the app and write down your questions, concerns, any kind of comment, and we will try to address them. Rodrigo is in charge of gathering the questions, and we will try to go through them through the session. So there are a couple of objectives this afternoon. The first one is to try to understand the remaining anatomical selection criteria for transcatheter tricuspid valve replacement. You will get a kind of update on the latest data that we have concerning that technology, and we will go, if not step by step, through a quite thorough assessment or description on the way that the device is deployed. So at the end of this session, normally you should have enough information to understand more about the technology. It's extremely promising. It's only the beginning of the journey, but we have a lot to learn. So the first speaker is going to be you, Rodrigo, about the data and what we have today about the technology. So thank you.
Thank you, Didier. I'm not as good speaker as Jörg, but I will try to make my best, showing the latest evidence on the Cardiovalve tricuspid device. Let's see if it works. Please be as interactive as you want, make a lot of questions. We have a super expert panel, and probably we can address all of them. So I thank George for these slides. This is not my conflict. So TTVR is trying to cover in a significant unmet need. We know that the most widely used transcatheter therapy for TR is the edge-to-edge repair. But edge-to-edge repair, has several limitations in some particular anatomies, like leaflet clefts, leaflet configuration. We know that the tricuspid valve is not so tricuspid. It has multiple scallops. That makes more complex. The tethering and the remodeling of the ventricle and the huge annulus cases, these are creating less success than expected with TEER. And this could be also problematic for the future if we leave an unsuccessful TEER device in the valve because it's closing the gap for other options. And of course, if the result is not good, we have risk of recurrence of significant TR, also associated with poor prognosis. So this is a couple of examples where TR is not gonna drive us to a good result. So the solution we have for those patients not amenable for TR is that we bring in this symposium is Cardiovalve. That is a valve, very innovative design with minimal ventricular protrusion. It has a firm anchoring based on the sandwich of the leaflets and the annulus, and with a special mechanism for preventing PVL, that is this inflatable cuff that is created with the dacron between the two frames of the valve. Has no radial forces and fits a wide range of anatomies. We see here we have 3 sizes from medium to extra large, fitting annulus up to 55 millimeters. This is how we deploy the valve. It's 1 valve, 2 frames, 3 steps. First is position in the center of the valve, then opening the ventricular legs in the atrium, going to the ventricle, capturing leaflets, and then expand the atrial flange and the whole valve. Talking about data on the use of this device, we have published some months ago the compassionate use patients. It was 20 patients. This publication was led by NILFAM. The population was elderly and comorbid population, as expected in the compassionate use, almost 80, with advanced functional status and a lot of comorbidities. Interestingly, massive and torrential TR is around 90%, so really advanced cases. And of course, patients as well as some deterioration in renal function and prior background on heart interventions. The most frequent size of the device due to this is the XL. So you will see this is a constant in all this data. But with this comorbid population, we obtain a significant elimination of tricuspid regurgitation with no much relevant events after the implantation. Of course, we have some bleeding, we have some pacemakers, but quite okay for the population. With this promising result, the company launched the target study with the objective of evaluating the Cardiovalve TR system in a procedure for reducing tricuspid regurgitation, signs and symptoms of TR. It's a prospective single-arm open-label multi-center study that plans to enroll 150 subjects. We crossed the border of 100 subjects a couple of months ago. It will be done in 45 investigational sites across Europe, US, and Canada. And those patients that is the target of the population are patients symptomatic for at least severe tricuspid regurgitation and at high risk for surgery, and that are deemed eligible for the evaluation committee. And the follow-up plan for these patients is 5 years. These are centers that are participating currently: Germany, Spain, Italy, UK, and Canada. And these are the major points for screening. Patients should be between 18 and 85, with at least severe TR, symptomatic, with non-severe LV dysfunction, no precapillary hypertension or extremely high pulmonary hypertension, not so frail, right ventricular dysfunction should be less than severe, GFR should be more than 30, and life expectancy should be more than 1 year. And of course, we have some anatomical criteria, that is the diastolic annular diameter between 35 and 55, and the geometry of the ventricle that fits with the valve, and also very important, should be secondary TR patients. We cannot include primary PR patients. So far we have included in the study 105 patients. Mean age is 72, 70% female, advanced status from a clinical point of view, and with a lot of comorbidities. Very interestingly, and this is important, massive anterolateral TR, almost 85% of the patients. This is much more than the TRISCEND-2 study, so these are more advanced patients. And again, the most frequently used size is the XL. What we can disclose now, because this is an ongoing study, is a high proportion of TR elimination, almost 95%. And we also have quite early data of right ventricular reverse remodeling. This is echo core lab analysis. We diminish the right ventricular end diastolic and end systolic area, decrease in the IVC diameter, decrease in the right atrial volume and the right atrial pressure. And just to show you an example, this is the first patient included in Target in the George Nickeris Center. Now it has been 2 years follow-up. Patient is doing really fine. You see the remodeling, no TR. Ventricle is much more smaller, and you see all this data like they are supporting the inverse remodeling and improvement in the right heart chambers. So the take-home message is that these are two devices that's one device that fits both mitral and tricuspid. It's a transfemoral procedure, very safe. We are improving a lot and learning a lot. Initial clinical results are promising, and since innovation continues and continues, I had the privilege last week of seeing the first mitral case Cardiovalve implantation in Gaia with the new delivery system, and I think it's going to be also a game changer, and that's all. Thank you so much.
Thank you very much. So we have a couple of minutes for discussion before we move to Javier. So one of the objectives of the session is to better understand the anatomical limitations. We now have more and more understanding about how to position TTVR, more about towards the contraindication or the not suitable case for TEER. If we focus on the Cardiovalve device, how would you summarize the unsuitability in terms of anatomical criteria? Because we nicely understand that it's a device that can fit a lot of anatomies. Which patient do you believe wouldn't be treated with the device?
Yeah, so first, regarding etiology, in Target and all the cases we have done have been secondary functional TR, let's say. So primary TR is not considered in those cases. Regarding anatomy, of course, annular size should fit between 35, 55. If you are below or you are above, probably will be a screen failure. And then you need enough room in the right ventricle, so you need some distance to the apex and to the lateral wall and to the papillary muscles in order to navigate the valve inside the ventricle. The offset of the cava, that was a problem at the beginning with the first generation, is not anymore since they added the lateral knob to move. So probably that's our main factors. And another factor is that its capsule is still large, and you need a fine navigation through the venous system. And in order to decrease vascular complications, that was one of the main points of TTVR, we also analyze the trajectory, and in case of some osteophytes in the column that are protruding in the veins, we say this is anatomical contraindication for navigation.
Thank you. So Federico, we nicely saw the impact of this device, as it is the case with a lot of TTVR device, but it's quite impressive here, the impact on the right ventricular remodeling, getting rid of TR, it's exceptional. Do you believe that we need a larger valve size?
Yeah, well, I think the tricuspid annulus really can reach huge dimensions. So one of the screen fail causes for most of TTVR devices, obviously not only Cardiovalve, but also the Evoque system and many others, is actually annular size. So I think we really need to think in that direction and to try to in order for this therapy to be more to serve more patients and to be useful for more patients. I think in the future we're going to see many more XXL sizes across different platforms.
And maybe one final question to you again, Rodrigo. We understand the anatomical limitation in terms of diameter of the tricuspid annulus. We all have the tendency now to prehab our patients with the diuretics, fluid management. Do you believe that this should play a role for the Cardiovalve system, just to shrink a little bit the right ventricular dimension before going to the procedure, or that's something that you would avoid?
What we try to do is to have the patient the most optimized possible. So optimize preload and contractile pattern of the right ventricle in those with failing ventricles. So we don't pursue like shrink the ventricle completely, like favoring edge to edge, but rather to be in the euvolemic state and prepare for the ventricle for the correction completely of the TR.
Didier, I think we have also questions. It's going to be for Roy. He cannot read a question to himself.
I was waiting for you.
Where are your glasses?
So when the TR was not fully eliminated, what was the source of the regurgitation? It was intra-valve or peri-valvular leakage?
Yeah, if we remove some like malposition cases that happen at the very early experience, what we see now is PVL. Intravalvular, we haven't seen any TR, but we have seen some PVLs. Also, this is important that depends on the moment that you analyze it, because this anti-paravalvular leak inflatable cuff takes some time to eliminate those PVLs. So probably if you do it very early, you have more PVL than at 3 months, 6 months.
Thank you. So Xavier, Xavier or
Xavier.
Xavier, I like it.
It's French.
So Xavier is going to share a case, a live-in-a-bug case that is very interesting. So thank you.
So I don't know what you expect about a happy wedding. It's not mine, but we'll see. These are my conflict of interest. First of all, I would like just to thank for the invitation. And I'm going to present a very young man. It's a male, surprisingly young, that actually, was, in this session, and we're like considering for this therapy due to 2 previous surgery, cardiac surgeries, especially the last one with a very bad experience from his part. And the patient after that experience, very severe, massive torrential TR, very symptomatic. The patient was really symptomatic in NIHA 3. We performed the right heart catheterization showing no pulmonary hypertension. And here the characteristic that maybe makes the difference for, as you will see at the end, it's the previous pacemaker implantation. So the patient had a lead of pacemaker. So basically, the patient, due to, his will, he didn't want at all just to have surgery and was evaluated for transcatheter and tricuspid valve replacement because the anatomy was not suitable for Cardiovalve, was not suitable for edge-to-edge due to a big gap and bad anatomy. So at the end, we performed the angio-CT and the TE, and the patient actually was eligible for this system. At that time, we're participating in the target study, like Rod said, and the patient could be included in this study. So the patient was done, on fluoro and TE, and we decided to implant a large-size Cardiovalve tricuspid for him. So this is the video of the baseline tricuspid regurgitation. And actually, you see that we use initially, in general, an Agilis with a pigtail, or you can go directly with a Safari. The patient, as I said, had a previous surgery, cardiac surgery. You can see the mechanical aortic valve there. So we use this balloon in order to see that we're completely free. When we're crossing the valve and there is no interference, so the catheter and everything feels completely free. And after, we go with this full transfemoral system that actually with the new modifications, it's super smooth. And actually, there's no problem. We haven't experienced any problem with this system. So the system advanced really. And as you can see, we at this point, you start just to advance. You have just to keep an eye, of course, in the Safari wire, and start to flex it. Advance flex, control the wire. And in this, as you can see here, there's also, the lead playing a role. So they don't want just to get trapped. So at the end, you will see that we made some modifications just to make it free. Because you don't want just to get too trapped and just to apply a lot of tension to the system. And at the end, you can see that now the lead is free. It's in a posterior position, and the valve, it's more in a central anterior position, so everything is completely free. So at this point, we start just to open the valve. We make sure that we are in the center. Here, like in any other valve, optimization of the coaxial approach, it's a key factor for a success of the intervention. So we have to make sure in the X-plane, that we are, completely targeting the valve in a perpendicular way. And then we start just to open the wings of the valve in order to get, grasp of the leaflets, as you will see. So I'm just going to advance a little bit. So now here, what we are doing is just position. And the system has now, new features, novel features to correct any, just bad position, any, mispositioning in terms of septal hugging, in terms of height. So you have, the proper, that now it's just too complex maybe to explain, but all the proper knobs to correct any misposition. And as you can see here, we have, the wings open, and we're just going to go, beneath the leaflets and start just to open. This time, you have all the time, just you can check, you can see, you can ask, you can check, recheck, and there's no rush. So at the end, after checking in NPR, after making, a complete flip, so we check that the valve is in good position. And if everything's fine, as you can see here, so we start just to release it completely, as you can see here. It's like this last step, it's quite fast. Here, the valve is completely free. And as you can see, we remove the system, the pigtail, and the nose cone, of course. Here you can see the valve deployment, that it's quite fast, but at the same time, control. And on the right side, the final result with no PVL, no nothing. I mean, complete abolition of the TR. And why? Like it's the wedding, because actually this patient, as I said, it was 59, and we performed the intervention on Wednesday. The patient was discharged on Friday morning, so that night took a train from Barcelona to Zaragoza, and on Saturday he attended a wedding without any issues. Actually, like just the guys that were getting married, they didn't believe that he could come, so they keep a picture, and they put a picture on the chair, but the guy did it, and he was super happy. So at 3 months, at 1 month and 6 months, the guy is doing great. So he's in NIHA 1, no PVL, no TR, good gradients, and very good functional performance with 710 meters. So basically, the take-home messages of all of this is that I think that we're moving, in this field towards, a more, I would say, just rapid and a more dynamic field. So in these selected patients, especially the ones with LEDs, like defibrillator or pacemaker LEDs, I think that rapid discharge, 24, even 48 hours, it's feasible. And as you can see, if you select well the patient, I mean, you can just do the same thing that you will do in a TAVI or an edge-to-edge repair. Thanks.
Thank you very much. So once again, feel free to ask anything, and we're going to address your questions. So there is one question for you. Be ready, because it's going to be challenging.
Well, maybe not for you, maybe for everyone. Thank you for that. The presentation has been really helpful and very interesting. It's really exciting to see this valve. It just looks like it's going to do wonders. But my question is, as an imager, about the right ventricular function. Do we have any thoughts on what is too bad? And how do we measure them? Is it on echo? Is it 3D, LV, RV ejection fraction? Is it MRI, RV ejection fraction? Just GLS? Well, how should we do it? What's bad and what shouldn't be done?
I think that this is a learning, field. Of course, I think that we don't have that information. Cardiovalve will behave like any other valve. I think, that will abolish completely the TR, even like a heterotopic valve. So, the right ventricle will have to face, a new dynamic situation. So we don't do MRI. I mean, we're just doing echo assessment. And if the patient has more than moderate impairment, we will think a lot, and maybe we will pre-treat, the patient with levosimendan or other drugs. But it's for sure that this is like a burning question that probably there's no answer yet.
And at the time of the procedure, have there been any cases where the RV's been very unhappy and you've had to, abort?
Or to support?
For me, not so far. I don't know, the rest of the panel.
No. In our experience, some patients develop right ventricular failure after the procedure because you completely eliminate TR, and probably those have right ventricular dysfunction that are clearly not evaluated well beforehand. But usually they are quite well managed with inotropes, and it's like a transient response that they recover in a few days.
And it's quite impressive. You've seen a couple of cases since the beginning of the day, and you see how stable the patients are through the procedure. But I guess your point is very important. We need to assess in a thorough way the right ventricular function before the procedure. If it's too bad, we may expect either not a hemodynamic compromise during the procedure or a bad recovery, a poor recovery of the patients after that, futility. Yeah. So I think your point is very well taken. It needs to be assessed before. How we assess that, it's just we all need to learn together, and multimodal assessment, I guess.
Thank you very much.
Thank you for your question.
So I will make a question to myself now, just to you.
And Federico is going to answer that.
No, because you were talking about, pre-treatment. So what what I have experienced with all these valves, it's that after implantation, patients slow down. Of course, sometimes they block, sometimes not. but sometimes they slow down, but eventually they don't need a pacemaker. So instead of like just giving diuretics and all this, should we skip all the inotropic drugs, beta blockers, digoxin, the day of the intervention or before the intervention? Because my feeling is that when I discharge this patient, they end up without anything. So that's a question that.
Yeah, that's a very good comment, and it's a very good strategy. There are also, centers which are really taking away all these beta blockers and inotropic drugs before TAVI, and apparently they have better results in terms of pacemaker rates. So, I mean, the mechanism of pacemaker after a TTVI is quite similar to what we see with TAVI, except it's on the other side. So why not? Any drug affecting conduction can be withheld.
So if you want, we're going to continue that conversation afterwards. It's very important, this issue of conduction disturbances. But let's bring back the discussions towards imaging. And Sergio is going to drive us through potential novelties in the field, and now we can increase the quality of the imaging that we have.
Thank you, Didier. Before to introduce the case, I want to share with you a couple of slides on the concept of ICE. One of the main aspects for the tricuspid intervention is to image the tricuspid. The TOE shows some limitation due to the fact that the leaflets are thinner, but mainly because the position of the probe in the esophagus is far from the valve. So we know that if you increase the distance from the probe to the target, the quality of the imaging is going down. And because in the middle we have the mitral valve that sometimes is fibrotic, calcified, and the shadowing effect could be important. One of the other main aspects is that it's very difficult to have with the TOE an in-phase view of the valve. The perspective of the ICE is completely different because the main advantage is that we can advance the probe inside the right side of the heart and in front of the tricuspid valve. So the quality of the imaging is extremely high, and the interference with the catheter or delivery system is extremely low because the catheter is steerable in all directions. And our strategy is to advance the probe from the right jugular vein, so the quality of the imaging, the interference between the probe and the delivery system of the device is reduced. And this is the setting of the cath lab. The ICE probe is managed by the imager that is in similar position to the TOE, and the two interventional cardiologists are free to manage the procedure. This is the setting of the cath lab. I introduced the case. He's 77-year-old female with comorbidities, arterial hypertension, permanent atrial fibrillation, and hypothyroidism. She received a surgical procedure in 1995 of atrial septal defect correction and reconnection of the pulmonary vein and enlargement of plastic of superior vena cava. In 2007, she implanted a pacemaker for an heavy block, and then after she experienced atrial fibrillation. And at the outpatient control in 2023, she was detected a severe tricuspid regurgitation. The Euro score is 5.19, 3-score 4 on 12, and valve score 1 on 4.5. The patient was treated with the optical medical treatment, and on the base of the planning that Roy explained before, we evaluated the sizing of the annulus, the working projection, and this is a summary of all the parameters. And on the base of this CT scan planning, we decided for an X-large device. This is the view of the fluoro and the view at with the eyes. One of the main tools that is extremely helpful for the procedure is the MPR. The MPR means to have the visualization of the same point from 3 different orthogonal point of view. This is the device alignment, the visualization in the one shot of the 3D and 3 main planes of the device is essential. Now we are pushing to cross the valve. You can see the TOE and the ICE in parallel. In this case, we use both for 2 reasons. First, because the target for the target study is expected to use the TOE, but the second is a confirmatory role of the TOE because we are at the beginning of the experience with the ICE. And this valve crossing, you see clearly the visualization of the leaflet, the visualization of the device, and the position in an end-phase view of the tricuspid valve and same time of the device. We are assessing the position and the capture of the leaflets. You see clearly the position of the leaflet that is touching the device when the position is correct, without moving the probe. One of the main advantages of the ICE that you park the probe, you block, you acquire the volume, and you work. And you see the quality of the imaging during device deployment, and it's clear the removal of the device. You see clearly if the device touch or not the valve, and this is the final evaluation with ICE. You see the 3D view and phase. It's perfectly in phase with the 3 main planes, and you can rotate the plane and you can evaluate the position and the regurgitation. You see the excellent result with 0 regurgitation, 0 leak, and this is exactly the same view with the TOE. The quality of the imaging is exactly the same. Probably the quality of the ICE is just a little better. The new generation of the device with a larger field of view and in a high frame rate will improve the quality of the imaging, and this is the follow-up with a perfect quality of the result and near class 1. And my conclusion is that 3D ICE is a breakthrough technology. It can provide more consistent imaging of the cardiac structure, avoiding the conflicts with the device and with the other structure, because the main advantage is that we can advance the probe close to the target zone, and the transcatheter valve, tricuspid valve replacement is a new technology. The combination of these 2 technologies is the secret for a procedural success. Thank you to all the team. Thanks so much for your attention.
Thank you, Sergio. So that was a very nice case, and it speaks about the potential utility of ICE. So let me ask you guys, who is an imager, echo specialist? Raise your hand. So no one. You are. So do you have experience with ICE? Never. No, never. Would you mind grabbing the microphone, because you've seen the case from Sergio. Do you believe that it could be useful for your practice? What do you expect from ICE?
Okay, I expect easier view, because I guess that you can have the shadowing artifact, and this can be helpful. Even if I know that they compare TOE and ICE, in this case I can say that because the thin texture of the leaflet can be easily seen by TOE than ICE. So it's just growing, improving, but I'm very involved and interested in this procedure, as Professor Berti knows, because we want to implement in our hospital center. So according to my opinion, is an interesting tool.
Okay, thank you. So this is a very positive feedback, and you wanted to react as well. Please go ahead.
So I'm an imager too, and I just wanted to say, from ICE is great. We've been waiting for the 3D to come. Amazing.
Yeah.
It's this narrow angle of view, and obviously that will come with time. I'm sure it'll all improve. I think the biggest thing for the imager in the cath lab is you want it to work seamlessly with your console. So that's one thing I would say is the practical aspect. So I mean, someone else is moving the probe fine, but you as the imager, interventional imager, it requires a lot of 3D multiplane, a lot of understanding, cropping, resetting things, and you need to be able to work seamlessly between the imaging. So what I find is with TEER cases, if you're doing it, you might have an ICE probe in, but you still have the TOE probe. You might park that in the transgastric to get your short axis, and then you're looking for the grasping view or whatever you're doing. So you need to be able to move through the system. So my appeal to the companies is really to get good at doing that quickly, so we can move through the two on the same console.
Exactly.
That would really be the ideal. Yeah.
So more ergonomy for our colleagues, imager, please, from the company. One question to you, Sergio. Beautiful images. There is still room for improvement. 4D eyes is going to improve. Do you believe that one day we will have only procedure eyes guided?
Yes, this is the dream.
So this is a statement.
Yes, I think that the next future, it's my personal opinion, all the procedure could be done only with eyes if we will have the cooperation of the imager, because the quality of the imaging is much better if it's the imager that manage the eyes. We changed the approach, the strategy from the jugular vein, mainly because to reduce the interference between among the interventional cardiologists, but mainly because the imager is free to manage the probe similarly to the TEE management. So and the quality of when he decided that is the imager that has to manage the eyes probe, the quality of in our cath lab, the quality of the imaging increased a lot.
Yeah. So potentially in the future, we could imagine that the echo specialist is scrubbed with the interventionalist at the table and handling the eye scrub.
Yes, I think that in the next future, we move toward the professional profile of interventional imager. It's a new figure that we need of this kind of profile that is not exactly an imager, but is something. Is an imager with experience that of cath lab and of devices.
Thank you. That's a very nice perspective. So let's move to your case now, Federico.
Yeah.
A challenging case.
I would like to share the case because Roy was saying that all were secondary cases. This case also has a component of primary tricuspid disease. So the patient is a 72 years old female with permanent atrial fibrillation, some degree of chronic kidney disease, and her cardiological history starts back in 2009 in her late 50s when she had a mitral valve replacement with a mechanical St. Jude valve. And in the same surgical procedure, she had also a De Vega annuloplasty. The De Vega annuloplasty is a very loose suture which is run around the tricuspid annulus, just stitches and pulled together. So it's not very strong, it's and is also not really effective, we could say. At that time she had tricuspid regurgitation, then she had obviously over time a recurrence of tricuspid regurgitation which led her to increase the diuretic doses over time up to the point when in March 2024, so less than a year ago, she had an episode of acute right heart failure and basically this torrential tricuspid regurgitation was addressed. She got referred to our hospital for transcatheter treatment of the tricuspid valve. This is some baseline echo imaging. You see that the degree of TR is torrential. The vena contracta is 21, and from the 3D images you can clearly appreciate how wide the coaptation gap is. And also from the top panel you see this sort of restricted leaflet motion in both the septal and the lateral. They should be the posterior leaflet. So a combination of wide coaptation gap and restricted motion, clearly the case is not feasible with TEER technology. The mechanism is double. On the one side, we have this restricted motion, which is combined with some degree of annular dilatation. I think this, again, these CT scan images show really the limited motion over the cardiac cycle of the tricuspid leaflet. And this dual mechanism is the reason why we could basically enroll her in the trial. Otherwise, primary tricuspid regurgitation is an exclusion. In this case, it was mixed. In the trial, the very severe right ventricular dysfunction is excluded. This is RV volumetric analysis. We had some doubt on the degree of right ventricular dysfunction. This is why we had this 4D CT analysis analyzed by Ori Ben Yehuda and the San Diego University. And we understood that significant akinesia is limited to the septal wall. So the other areas of the right ventricle are nicely functioning, as you can see also from this 4-chamber CT scan view. And so basically, again, we could enroll this patient in the trial, which I'm very glad because the outcome is good, as you will see in a second. You've seen the procedural steps. Again, I think it's important that the mechanism of the cardiovalve fixation is on the leaflet, and when we have this restricted leaflet motion and this thickened leaflet, this can provide a kind of a secure anchoring within the apparatus and provide a nice stability of the valve. The procedure was carried out with a standard right venous access. We found our nice coaxiality. We crossed the tricuspid plane in the center. We adjusted the position of our valve as Roy taught us. And then we opened the anchors of the valve to ensure the positioning of the leaflet within the anchors. We checked with this rotation multiplanar reconstruction on echo to have a nice positioning of our leaflets. And then once we were convinced of the position, we opened the atrial flange to secure, as you see here, some bubbles coming from saline appear in the echo image, and the atrial flange is open, and at this stage you see here on the bottom we release also the lower portion of the valve. This is the transesophageal echo result with a complete, almost complete abolishment of tricuspid regurgitation from torrential to trivial. The transvalvular gradient is 3. Before discharge, obviously, the patient was checked on transthoracic echo, showing again a very good result with no significant gradient across the valve, and we were able to reduce the furosemide dose of the patient from 375 milligrams of furosemide down to 75 milligrams per day. At 1 month follow-up, the patient is feeling very well. So I think we still see rheumatic disease in Western countries, and obviously these patients, after they undergo left heart procedure, this rheumatic disease, tricuspid valve disease can be an issue to treat because of a complex anatomy. And also, TTVR is probably a good solution for this patient, and TTR is very difficult to consider. So I think TTVR ultimately with Cardiovalve in this case is an excellent option to reduce or abolish TR for these patients. Thanks for your attention.
So there is we've seen, and we're going to see through the 2 days and a half, 3 days of London Valves, several TTVR devices with different expansion mechanism. So Federico, can you tell us why it is important to deploy the very first part of the device above the tricuspid annulus? Because most of the devices, for instance, the Evoque platform, you start below the leaflet and above the papillary muscles. So maybe it's important for the audience to understand that this is a different device and different expansion mechanism.
Exactly. So the anchors for this device need to be expanded above the device and above the tricuspid annulus, and then you advance the device down like you would do with a tri-clip or with a Pascal to go and actually get the leaflets above the anchors. This is one of the important differences with this device. And also ultimately, thinking about this specific anatomy with thickened leaflet and restricted leaflet motion, this is even more important, because if you deploy too low, then you want to avoid getting entangled in the apparatus.
So very important, and I think when you're going to get that device within your institution, your cath lab, so it's very important to understand that the way it's deployed differs from the other platforms, and if you want to make sure that you achieve the exceptional outcomes that we've seen through the cases, even in challenging situations, we need to understand and to learn the step-by-step deployment of it. So maybe Xavier, while Rodrigo is getting to the podium, we can come back to your point about the conduction disturbances. Let's imagine that the patient has no right ventricular lead. We know that conduction third degree AV block can be one of the issues with TTVR systems. How do you anticipate that at your institution? Do you have tips and tricks just in case the patient develops a AV block during the procedure? How do you handle that?
Well, it's also a difficult question, but what we're doing, I think that maybe compared to TAVIs, I think that sometimes it comes a little bit slower. So, usually in TAVIs, of course, you can see after just 2 days. But in these patients, what I've seen especially that they slow down. Sometimes they develop this first degree. I mean, if the patient keeps on a first degree and there is no an advanced blockage, so we try, just to stop those medications, beta blockers and all this. Of course, if there has been like any issue because of the lack of experience, we keep the patient for 4 days, 5 days. But I mean, we don't do anything else. Maybe like extra precaution, because I think that we don't have yet that much experience.
Xavi, what happens? It's rare. Actually, we had not with the Cardiovalve, but with a different platform, a patient blocking acutely on the table. In that case, you might want to think about pacing on the Safari wire, or even placing in the left ventricle a wire just to pace. Because that's
Enrico, how many hour a day do you expect before an implanted pacemaker if you have an AV block?
That's a very difficult question, because what Xavi said is really true. These patients slow down and they do not.
We have the effect of the mechanical impact, firstly, and then the small hematoma due to the traumatic contact between the mechanical device and the tissues. So probably the hematoma or the edema, tends to reduce, but the question is,
Sergio,
how many days
these patients
should
also
be monitored
have an important degree of remodeling, which happens really in the next few days. So that increases contact between the conduction tissue and the device. So I think this is something we are really starting to learn.
And also, I think that if the patient is on this medication, it's also important. The other day, last week, they called me the day after, from the emergency room. So should we put a pacemaker, a Micra, whatever? I say stop. Is the patient taking digoxin? Is the patient taking bisoprolol? And they told me yes. So wait. So then the patient, wait for 2 days, and now he doesn't require, pacemaker. So I think that in those cases you need to slow down a little bit and maybe wait a little bit.
Expect a little bit. So, Rodrigo.
Yeah. So what I want to show you is what we have done in my center last couple of years with the Cardiovalve, how fast you can accommodate and introduce this new technology. I should have some potential conflict of interest, but functional tricuspid regurgitation is the predominant etiology, of course, and severe TR is associated with unfavorable outcomes. And what we're gonna highlight in this presentation is the how we do it in our site, managing these patients with severe tricuspid regurgitation with TTVR device. So in our center, the last couple of years, we performed 12 cases using the Cardiovalve system. All patients had, of course, at least severe TR at baseline. All underwent CT, TT, TE, and right heart cath before the procedure. And we, of course, follow the patients with data collection, baseline discharge, 30 days, and then 6 months and 1 year, those we have. During these 2 years, we screened 24 patients for this Cardiovalve, and the screen pass for this is slightly above 50%, which I think it's, if you compare it with the mitral space, is less depressing, let's say. In the mitral space, we send a lot of patients, most of them were rejected, you get depressed, you don't send more patients. So here, the acceptance rate could be more than 50%, and you can increase that by looking a little bit at the images before sending to the company. I mean, just quick analysis on the circularity of the annulus, that you respect this, the diameter, the maximum diameter, and the shape of the ventricle could be enough for not failing so much when you select those patients. From the procedures we did, one case was aborted because we have a vascular complication. So for these 12 patients, mean age was 74, most of them females with very symptomatic, high risk and with comorbidities, and 1/3 of the patients with a prior heart failure hospitalization. Massive of torrential, almost 80%, as I mentioned before, very different from TRISCEND 2. And here is a little bit more splitted, but anyway, XL was the most common type of device used. Mean tricuspid annular diameters were 46, this is why XL was the most common, and right ventricular function was preserved. We had procedural success 100% in all patients, and all the patients with known or traced TR at 30 days. And a mean follow-up of these patients, almost 1 year, all patients were alive. One received a permanent pacemaker in the following week of the implantation, and almost 90% of the patients were in functional class 1 or 2. So at the end, technical success was achieved in 92% of the patients. This is another important piece of information, because when we started the procedures with the old system, it took a lot of more time, because the old system to be introduced inside the cut-down access was much more complex. But with the enhanced delivery system now, the time of the procedure in the last 5 cases has come less than half an hour, which is amazing for that device. This is the TR reduction we have in our patients, and with some, of course, adverse events, mainly bleeding was the main events. And we have also one patient with a pacemaker. Regarding results, functional results, huge improvement in quality of life and in 6 minutes walking distance. And also, we have some CTs of control of those patients during follow-up. And as we can observe, there's a significant decrease in right ventricular dimensions and the right atrial dimensions as well, almost significant. That means that the TR elimination produces a significant impact in the right heart chambers. This is an example. Huge dilated right ventricle, almost 400 milliliters, and at some months after, it almost goes to half. So just to conclude, this is just experience of one center, but it supports the use Cardiovalve as a novel TTVR system. The procedure is really reproducible and is consistent with the results we have. Learning curve over time shortens the procedure, of course. We see significant inverse remodeling with improved clinical outcomes, and of course further studies are required to analyze the impact of these findings in the prognostic of the patients.
So thank you, Rodrigo. We are coming to the end of the session, but let me ask you one thing. So we saw that 100% of your patients were on atrial fibrillation. It's a quite common finding with functional TR. So I guess all your patients are going to be under anticoagulation. If we shift the focus towards patients in sinus rhythm, what would you advocate in terms of anticoagulant therapy?
Yeah, so I mean, what we have learned from the surgical series is the right heart prosthesis has higher chances of thrombosis, and we have some experience with transcatheter platforms. If you cut the anticoagulation 2-3 days, you can have halt or high gradients. So even though in sinus rhythm we anticoagulate the patients, if possible they tolerate for life. And in our region, we have to start with warfarin. And so that's what we do. We start with warfarin in case something is wrong and we have to change to DOAC. We change to DOAC. We haven't seen any difference between those patients on DOAC or warfarin.
Thank you. So, guys, so I think we had a very intense discussion. So thank you for sharing your perspective and experience. So what did we learn? We learned about the anatomical selection criteria for the Cardiovalve device and for TTVR in general. We did as well learn about the importance of imaging and potentially the future about the implementation of ICE to guide the procedure, because imaging is central for mitral. It's even more important for tricuspid, I would say. We discussed a little bit about the outcomes that could be expected for our patients with this type of platform in terms of total elimination of tricuspid regurgitation, a favorable impact on the right ventricular remodeling, reverse remodeling, apart from the improvement in the quality of life of the patient. So we're going to work and improve the patient selection, and potentially in the future there could be an impact on survival as well. So I would conclude by saying that the future is extremely exciting. More devices are going to be available for our patients, but already the Cardiovalve is already a very nice option, and we are looking forward to having it available. So thank you guys for sharing your experience. Thank you for attending the session and sharing your comments and your valuable insights. And I would like to thank Venus and Cardiovalve for hosting such a very intense and nicely interactive session. Thank you all, and all the best for the rest of the meeting.